The exam begins by establishing that there's full knee extension and it's symmetric. And then I'll do the whole exam on the uninjured knee. Check for stability to anterior, posterior, to varus and valgus stresses. And then check the menisci with the McMurray's maneuver. I'll then go to the injured knee, the operative knee in this case, and do a Lachman's exam. Notice the excursion of the tibia anteriorly on the femur because of the deficient anterior cruciate ligament. Then I'll do a pivot shift exam. So with loading of valgus stress, the tibia goes from subluxated to reduced with clunk. We'll see two views of this. Again, I'm internally rotating, loading with a valgus stress. It goes from subluxated to reduced. Here's a repeat of the Lachman's, the pivot shift, and then I'll check for stability to varus and valgus stress in full extension, and then about 20 degrees in knee flexion. Check a posterior drawer, and then see if there's any clicking or clunking with McMurray's maneuver. The Lachman's is repeated. Notice the increased excursion of the tibia on the femur. The pivot shift shows the tibia going from subluxated to reduced with knee flexion. Stresses are placed to the knee in varus and valgus, with mild flexion, and then a posterior drawer shows no increased excursion. Flexion, rotation, feeling for a clunk, tests for meniscus pathology.
If examining a male patient, I may request they remove their shirt and observe the act. After they remove their shoes, I ask them to stand and walk across the room, observing them transfer and noting their gait. I have the patient walk on their toes to test S1 motor strength and walk on their heels to test L4, L5 motor strength. While standing, I perform an axial push. Giving way in pain is an inconsistency. I observe their flexion, mainly to detect gross restriction of movement and inconsistencies. Low back pain is the most common cause of disability in the United States. Inconsistencies on exam suggest that the psychosocial domains of pain are playing a major role. I check for 3 inconsistencies when examining patients with low back pain. Pushing down lightly on the head should not cause pain. Collapsing in pain during the axial push is an inconsistency. If the patient can bend over to remove their shoes, but is very limited when I ask them to perform range of motion, it is an inconsistency. The third inconsistency is differences in the straight leg raise sitting versus supine, which we will demonstrate later. If the patient has a history of trauma, other red flags, marked splinting on gait, or very limited range of motion, I palpate the spinal processes during my range of motion exam. However, the test is not specific, and without these findings, I don't typically perform palpation, especially for female patients. Performing inspection, palpation, and range of motion of the back assures the patient that I am examining their back. However, the primary role of my physical exam is to check for neuromuscular deficits, and there is no neurological examination of the lumbar spine itself. The 2 required tests of the neurologic examination for every patient with back pain are deep tenor reflexes and strength testing. We need to have a reflex hammer, and the patient needs to remove their shoes. To check deep tenor reflexes, I distract the patient by having them hook flexed fingers while I test the reflexes. The knee jerk tests L2, 3, and 4, but primarily L4. The ankle jerk tests S1. L5 is the most common lumbar radiculopathy we'll see in practice, but it has no measurable deep tenor reflex, which brings us to strength testing. Strength testing started earlier in my exam when the patient was asked to walk on their toes, which tests S1 motor strength, and walk on their heels to test L4, L5 motor strength. While the patient is sitting, Strength testing starts with the feet and great toes. Again, L5 has no deep tendon reflex, and its only autonomous motor is the extensor hallucis longus, which is tested by opposing dorsiflexion of the great toe. In patients with weakness, we need to differentiate if the patient is weak due to their pain or a neuromuscular deficit. Pain is a common cause of apparent hip flexor weakness, but is not typically the cause of weakness on examination of their feet and great toes. Besides strength and reflex testing, we often perform the straight leg raise. There are 3 points I would like to make about the straight leg raise maneuver. First, a positive test reproduces the sciatica symptoms. If no sciatica complaints in the patient history, the patient will not likely have a truly positive straight leg raise. Second, a positive straight leg raise should be found while the patient is both sitting as well as supine. Earlier in my exam, I performed the sitting straight leg raise while distracting the patient with my reflex exam. The sitting straight leg raise is much easier to perform and interpret correctly. A patient with a positive sitting straight leg raise will lean back and not let you straighten their leg. If the sitting straight leg raise is negative, but the straight leg raise supine is markedly positive within 20 to 30 degrees, it is documented as an inconsistency. Finally, the patient must relax and not engage the muscles. The third point about the straight leg raise is that the examiner, not the patient, lifts the leg during the maneuver. If the sciatic pain occurs, stop, lower the limb slightly, and dorsiflex the foot. If the sciatic pain is not reproduced, the lower extremity pain on exam is likely due to hamstring muscle problems rather than a nerve impingement. I observe the patient transfer from supine to sitting, and typically they turn on their side to sit up to avoid exacerbation of the pain. I again observe the patient step down from the exam table and put on their shoes. You may ask, what about testing sensation? I don't remember the last time I checked sensation in a patient with low back pain. Testing sensation is very subjective and has not been found to be sensitive or specific. This is the basic exam that I have performed on my patients with back pain for the past 30 years, and I hope this presentation was informative.